Good morning. Good morning, everyone. And I don't know how many people are attending, but you are having this whole month you will be having parasitology followed by examination. So this class is at most important if you are concerned with the near exam. If not also, then this chapter is very much mark fetching chapter for you. So do listen. Okay, let's start. I am Dr. Rosalind Das. I am assistant professor from Department of Microbiology. Okay. Coming to introduction, the class is amoebiasis. Okay, what do you understand by amoebiasis? Amoebiasis is caused by Entaamba histolytica. So, basically when we say amoebiasis, it refers to all the clinical condition which is caused by the parasite Entaamba histolytica, right? Coming to little history, the parasite was discovered way back in 1859 by Lambel, and in 1903 Squardin differentiated between the pathogenic and non-pathogenic amoeba, followed by Losch to describe the amoeba in the stool as round, pear-shaped or irregular form and which are in a state of almost continuous motion. Okay. Say from your background biology knowledge of biology, you must be knowing to describe something as amoeba, we have a certain kind of motility. What is that motility? That is a pseudopodial motility. What do you understand by pseudopodia? Pseudopodia is defined as a purposeful movement of the cytoplasm by projection. Okay. Coming to epidemiology of amoebiasis, it is found worldwide. And where do this Entaamba histolytica lives? The trophozoite of Entaamba histolytica lives in the mucus and submucosal layer of the large intestine of human. Right? Brief about the epidemiology. Entaamba histolytica is one of the most common parasitic infection of the world. It affects almost 50 million people worldwide every year. More common in poor communities with inadequate sanitation. Okay, poor hygiene where see this parasite has a fecal-oral mode of transmission. So in a community which is closely packed, which has poor hygiene practice, there we can expect its prevalence will be more. Okay. If we see the Indian statistic, the cyst excretion in India is approximately 3 to 47%. See the range, the percentage is wide range, 3 to 47%. It depends upon the community which you are testing, whether it is a child or adult or affluent society. Okay. So, and among the preschool in different country, it is found Sri Lanka 4%, Iran 15%, Bangladesh 6%, Venezuela 11%, and in developed countries like UK, US, it is 2 to 4%. Okay, amoebiasis follows a 10%. We have a mnemonic for it, that is 10% disease. What is that? 10%, it affects 10% of the world population infected by Entaamba histolytica. 10% of the infected individual are symptomatic. 10% of the symptomatic individual will suffer from mortality. 10% of the disease due to Entaamba histolytica are pathogenic species, and 90% of the asymptomatic people may be harboring other non-pathogenic Entaamba histolytica like Dispa, Mashkovi, and or other non-pathogenic histolytica also, which I will tell you how to differentiate what are non-pathogenic. Okay. Now coming to classification. Classification, it belongs to the phylum Sarcomastigophora, subphylum Sarcodina, superclass Rhizopoda, class Lobosea, subclass Gymnomovia, order Amovida, And coming to genus, when you come to genus, there are there are basically three main types: Entaamba, Indolimax, AIIMS. Okay, so in your exam point of view, you will be always asked to name few pathogenic and few non-pathogenic, right? At that point of time, you have to remember all this example. And even in your today is your first to parasitology practical, I think so. So in the practical also, you will be asked to show 3 pathogenic and 3 non-pathogenic. When they say 3 non-pathogenic, then this non-pathogenic species like Entaamba E. coli, Entaamba gingivalis, Indolimax nana, AIIMS bushli, that you have to show in the stool. Okay, which one is the parasitic one? Parasitic one is the Entaamba histolytica. Briefly about the pathogenic and non-pathogenic, as I told you, the pathogenica, Entaamba histolytica, Entaamba Bangladeshi, Entaamba hartmanni, Entaamba mashkovi, Entaamba poliki. These are the new over. See, histolytica has been found age wide, but the new Bangladeshi, hartmanni and the recent one which are getting added to the list of pathogenic amoeba. Okay. Now coming to non-pathogenic, Entaamba are Entaamba gingivalis. The name itself suggests it will be found in gingiva, that is the oral cavity. Intestinal non-pathogenic amoeba, Entaamba coli, Indolimax nana, Entaamba dispa, AIIMS bushli, Entaamba fragilis. Okay. Morphology. See, the amoeba, I told you, it has 2 stages, basically 2 stages. There is an intermediate stage also, pre-cystic, but basically it has trophozoite and cystic stage. The characteristic of the parasite, both the trophozoite and the cystic stage will be better appreciated in iodine and iron hematoxylin stain. Okay, the trophozoite is called growing or feeding stage. This trophozoite show slow gliding movement by pseudopodia. It has 2 parts, which is ectoplasm and endoplasm. Ectoplasm is the outer part, the clear translucent part, and the endoplasm is the granular part which has RBC leukocyte tissue debris. Okay, shape not fixed, size approximately 80 to 40 micron. Nucleus can be 4 to 6 micron with karyosome centrally placed. Right. Then intermediate stages, pre-cystic stage, very difficult to differentiate and very difficult to find it also. Smaller in size, 10 to 20 micron, round or slightly ovoid with blunt pseudopodia. Endoplasm is free of RBC and other fluid debris. Okay. And then finally the cystic stage, which we most commonly come across in day-to-day stool examination, and which your people are supposed to see in your stool examination also. A mature cyst is quadrinucleate spherical body. It is cytoplasm. Its cytoplasm is clear and hyaline. A early cyst can be uninucleate also. Cytoplasm consist of chromatoid bodies which are refractile long oblong bars. See, these chromatoid bodies are often called that you can see it in weight mount in 40x, but these findings are in freshly observed weight mount. Okay, so whichever stool you have been given, that is a preserved stool, that is we keep it formalin treated stool, so you may not see this point to point all the morphological features, but few are most, like glycogen mass you will see the number of nucleus, you will see the shape is retained. Okay. And one more point here, it is mentioned that the early cyst can be uninucleate. Okay, if a cyst goes through a stages of maturation, if it is a immature cyst or early cyst, there you can see one uninucleate will divide into binucleate, and a mature cyst will have a quadrinucleate, 4 nucleus, right? Coming to its life cycle, Coming to life cycle, as I told you, it lives in the intestine, large intestine of the human, that is cecum. Okay, fecal-oral route of transmission is the mode of infection. So what happens? Human get infected with the quadrinucleate machocyst, which is contaminated with food and water. Okay, so with food and water, the quadrinucleate machocyst human ingest, which reaches the mouth, and from mouth it goes to stomach. It invades the gastric juice or the acidic pH of stomach, and it goes to intestine, large intestine, first small intestine, then the large intestine. When it reaches the large intestine and it reaches the appropriate pH, then the excistation occur. Excistation, what does it mean? The cyst will rupture into a growing and feeding trophozoite. Okay, this trophozoite will come out. This trophozoite are actively motile with the pseudopodia. Okay, so this trophozoite will leave the intestine, will go to the lymph node. From the lymph node they will go to the blood vessel, and from the blood vessel to the inferior vena cava. From the blood vessel they will reach to the liver. They can reside in the liver, producing liver abscess, or they can reach heart, and from heart they can reach brain, lung, spleen, anywhere, any vascular tissue, and can get lost there and can produce the pathogenesis. Okay, subsequently I will tell you what is the pathogenesis. And anywhere, any vascular tissue, they can sit over there, they can have their nutrition, and they can produce a pathogenesis. Okay, this trophozoite will multiply by binary fission to produce multiple trophozoite, and due to certain environment like change in pH or certain antibiotic pressure, certain kind of adverse effect, they go into incystation. Okay, incystation means trophozoite will get converted into a cyst. First the cyst will be a uninucleate, which will convert into binucleate, which will further convert into quadrinucleate, and this quadrinucleate stays if present in intestine. If this trophozoite is in intestine or liver, it will reach the large intestine and to the rectus, and from there it will exit the host and go to the environment, and in the environment with food and it will contaminate food and water, and then it can infect subsequently another host. Okay. Now coming to pathogenesis of Entaamba histolytica, how the amoeba, which is most of the species are non-pathogenic or most of the species are free-living amoeba, why is this Entaamba histolytica is able to cause such a big damage to human body? How it is possible? As I told you, excistation of the Entaamba histolytica occurs in the lumen of the cecum. Trophores are the same thing which I described you in the diagram. The trophozoite invades into the tissue, then it multiplies at the margin of the ulcer. Okay, so very unique thing is that whenever when you will get into internship and you will go examine any patient, you will always think that the parasite or the pathogen will be most abundant in the base of the ulcer or where there is lot of debris. But unlike other organism, this organism doesn't have that much frequency in the debris. It always invades into fresh tissues. Okay, it always invades into fresh tissue so that there is abundant supply of nutrition for its growth. Okay, so therefore the ulcer which is caused by this pathogen is a flash shaped. It starts with a narrow bottle neck and then it spreads into a broad brace. Okay, subsequently I have the diagram. Dysentery flash shaped ulcer in the submucosa tissue, which will lead into superficial ulcer of the colon, small glandular foci of microinvasion, neutrophil infiltration of lamina propria. Okay, this is what it subsequently causes. Okay, people are leaving classes also, right? Um, then this is a diagram which explains um, how it happening, how what is the pathogenesis. Amoeba is adhering to the epithelial tissue of the intestine by its adherence factor, and which is a factor in human which is helping in adherence, nalci-lectin. Okay, this is a mucolectin layer which is present on the epithelial of the intestine. Intestinal epithelial has this lectin covering which provides adherence to this amoeba. Then and this amoeba gets attached, and the trophozoite of histolytica are known to produce lot of mucolytic enzymes, lot of proteinase enzyme. So the what are enzyme? Amoebic cysteine proteinase enzyme they produce, which digests this epithelial cell, and this amoebophore, they produce amoebophore which makes a tunnel into this epithelial cell, and then it gets a path to invade deeper inside into the submucosal layer, and in the by the time it produces so much of damage, there is sign of inflammation, there is activation of immune system, interleukin 8 is produced by this epithelial cell, lot of neutrophils infiltrate into the site for rescue. Then due to its proteinase producing enzyme, it digests this neutrophil also, and this inflammation goes on, and ultimately there is a superficial ulcer, and due to inflammation there is thickening of this epithelial layer also. Okay, the same explained in this diagram. That the gut has a normal nalci-lectin layer which gives a protective layer, but this EH has an affinity for that protective layer and can adhere to that layer. Okay. Main factor for adhesion may have a role in cytolysis, probably through stimulation of actin polymerization, and binds to C8 C9. Okay, that is what I explained you previously. Then transmission, how does it transmit? Reservoir of infection are men and monkeys also. Few cases have been found in monkeys, but monkeys still are doubtful. Mode of infection occurs through injection of cyst and fecal-oral route. As I told you, contaminated food and water are the basic mode of transmission of this cyst, whereas housefly, which sits over the fecal matter and then over the food, play a role in the transmission of the disease. And there are carriers also, like I hope you know the definition of carrier. Carrier are those which doesn't have the clinical signs and symptoms of the disease but carry the organism, right? Unconvalescent, those are those patients which are completely treated of entaamba histolytica. Clinically they are free of signs and symptoms of amoebiasis, but still they have a amoeba in their gut. Clinical features of amoebiasis. Okay, how does it present to you? Incubation period of amoebiasis is 4 to 5 days. What do you understand by amoebiasis? Used clinically to denote all the conditions which are produced in the human body by infection with entaamba histolytica at different areas of its invasion. Okay. First, coming to non-invasive amoebiasis. Non-invasive amoebiasis is nothing but amoebic dysentery. Okay. I hope you know the difference between diarrhea and dysentery. If you don't know, please do look into book and find there is a very basic difference between diarrhea and dysentery. These two terminology should not be intermixed. Okay, so amoeba entaamba histolytica is known to cause dysentery. Non-invasive, it causes non-invasive amoebic dysentery. Intestinal amoebiasis and extraintestinal amoebiasis. In intestinal amoebiasis, pathological lesions are found in the intestine. If it is found in the intestine, we tell it as primary lesion, and is secondary and metastatic can be found in the liver, lungs and brain. And extraintestinal amoebiasis, sometimes the amoebic ulcer may not be found in the intestine at all, and the amoeba directly escape through the blood vasculature to go to extraintestinal structures, and there it can produce its pathogenesis, right? Starting from lungs, liver, brain, spleen, it can invade any organ, right? So first, coming to the difference between amoebic dysentery and bacillary dysentery. What is the difference? Dysentery means passage of stool mixed with blood and mucus. Okay, blood will be there and mucus will be there. So, basic question when you will in your practical or sometime in theory will be asked, how by clinically by the history taking, how you will differentiate between amoebic and bacillary, and it is very important, and you are supposed to know it in your day-to-day life also, because dysentery are common problem, right? So people knowing that you are studying MBBS may ask you for the medicine, and so from few points you can catch up whether the patient need an antibiotic or whether the patient need anti-amoebic, which is metronidazole, okay, drug. So what is that? If in amoebic dysentery 6 to 8 motion, whereas in bacillary dysentery patient may have a urge for 10 motion a day. Amount in amoebic that is relatively more, whereas bacillary the frequency is so much that every time the patient goes for motion, he will have less fecal amount. Amoebic dysentery, it will have more offensive order. Color is dark red, I mean it will be maroon in color due to altered RBC. Okay, bacillary dysentery are bright red. Why it is dark red amoebic dysentery? Because trophozoite digest red blood cell. So once hemoglobin are digested, the leftover hemoglobin gives a maroonish or altered red color to the stool. Whereas in bacillary, bacilla doesn't feeds on RBC. The bright freshly passed blood will be there in bacillary dysentery. Nature, blood and mucus mixed with feces, whereas in bacillary very less, the frequency is so much that the blood and mucus are found more. Reaction, amoebic dysentery are more acidic, whereas bacillary are alkaline. Consistency, fluid mucus not adherent to container, viscid mucus adherent to the bottom of the container. So while going for microscopic examination in amoebic, you will find lumps of RBCs are present, whereas in bacillary discrete Rolex formation, you know, platelet and RBC tend to form a Rolex, so that is seen. Pus cell are scanty in amoebic because amoeba produce proteinases which digest neutrophils, whereas in bacillary dysentery it is numerous. Macrophages are very few in amoebic, whereas in bacillary they are large and numerous. Okay, eosinophils are present in amoebic, whereas very scarce in bacillary. Pycnotic bodies are very common, whereas it is not found. What are pycnotic bodies? They are the remnant of digested RBC, digested neutrophils. Okay, neutrophils will be digested. What is left over are called pycnotic body. Ghost cell are digested RBC which are left out, which are called ghost cell. These are found in bacillary. Parasite, trophozoite of Entaamba histolytica you will find, and in bacillary you may not see anything. Bacteria in culture will be positive in bacillary. And Cl crystals, charcot-laden crystal, which are composed of neutrophils and eosinophils, they are more common in amoebic. More common in what? They are found exclusively in amoebic. Intestinal lesions. Okay, so this liberated after this trophozoite liberated after excitation enters through the crypt of Lieberkühn and penetrates directly to the columnar epithelium of the mucous membrane by the amoeboidal activity. As I told you, the ulcer produced by this amoeba are flash-shaped. They invade the epithelium and they digest the underlying tissue to give a flash-shaped. Distribution of the ulcer generalized, they are the whole length of the intestine, and sphincter localized are ileocecal region or sigmoid rectal region. Character of the ulcer: size is pinhead to 1 inch or more in diameter, shape is round to oval transverse in large coalescing ulcer. Margin are ragged and undermined, base are muscular cold filled with necrotic material. Okay, extraintestinal amoebiasis. Liver is the next common organ to be involved. It is involved in approximately 2 to 10%, and mostly insidious in onset. Pain and tenderness is found, fever, jaundice, and it may complicate into granuloma cutis, which means the liver abscess will rupture into external skin, into lungs, right pleural cavity, below the diaphragm, into the peritoneal cavity. Okay, so symptomatic amoebiasis can be intestinal and extraintestinal. Okay, as I told you before. Extraintestinal amoebiasis, it can invade any organ, right? Pulmonary amoebiasis, cerebral amoebiasis, amebipericarditis, cutaneous, splenic, penile. These are few common one which we see in our clinical presenting, but practically it can invade any organ. Okay, coming to the lab diagnosis of amoebiasis, right? Now the patient can be symptomatic or non-symptomatic. In symptomatic amoebiasis, stool examination, when the patient comes with the complaint of pain in the stomach or intestine, blood in the stool, and tenderness. See, these are very insidious onsets, and even if the ulcer is there also, the patient does not come that overtly that I am having pain in the stomach. Okay, so in that case, stool examination is must if any patient is coming to you. Then macroscopic examination means you will see the gross morphology of the stool, what it is, and general microscopic, under microscope you can see charcoal leaden crystal, pycnotic bodies. Then in the weight mount, which you will be taught today in your class, when stool comes, you have to make a weight mount of saline and iodine weight mount, and you will look for entamba histolytica, cyst or trophozoite. Okay, if it is a liver abscess case and the clinician has sent you a aspirate of liver, then that liver aspirate you are supposed to see under weight. We have to prepare a weight mount and see it under microscope. You will find motile trophozoite, and that motile trophozoite many times have digested RBC inside it. Okay, so what is the definite point for diagnosis of trophozoite? See, they don't have a particular shape. They will have pseudopodial motility and digested RBC inside it. Okay, then this which I am showing you here, the charcoal leaden crystal, and this are the cyst which is having a glycogen mass. A glycogen mass will be better appreciated in a iodine mount, because iodine will give it a black color, and glycogen mass along with a uninucleate this is, and if it is a mature, then you can see quadrinucleate. Blood test will give you moderate leukocytosis, and serological tests are now available which gives positive for IgG. Some detect AIIMS. See, IgM detection means recent infection, and IgG detection means chronic infection. So logically speaking, IgM detection in amoebiasis doesn't make any sense, because all these diseases are chronic in nature. Okay, so in chronic cases, IgG gives a better outlook that yes, if in person might be having this chronic infection. But again, since in India we live in a compared society where the hygiene practice is not as good as developed countries, so in our country the IgG positivity is very high. I will say 90 to 95%. But again, only antibody positive in a patient does not indicate that the sign and symptoms may be due to entamba histolytica. There need to be multiple correlation radiologically, clinically, and even many times what they do, metronidazole being a relatively safer drug, relatively means it is a safe drug, they give a dose of metronidazole as just to and just to rule out other pathogen. Okay, lab diagnosis of asymptomatic, somebody is asymptomatic, is a child care handler or a food handler, then in them we look for the stool to whether they, if they are carrier, they can pass it on to other person. So in those cases we can find cyst. Okay, hepatic amoebiasis, as I told you, there are multiple discipline which comes into role to give a diagnosis: radiological, then diagnostic aspiration by surgeon, and that aspirate, if you see in wet mount, it will show trophozoite. Liver biopsy, examination of the stool, which can give at times give cyst of EH. Examination of blood, then serological test, intradermal test. It is a historical now, but it has option. Okay, then treatment of amoebiasis is easier one and safer one nowadays. It is oral or IV metronidazole. Okay, many times what happened, oral metronidazole is preferred for cases of luminal amoebiasis, means amoebic dysentery. Okay, where the trophozoite is in lumina and your drugs will act in the lumina. But the abscess which is deep seated, like liver abscess, like splenic aspirate, which is deep aspirate, this oral metronidazole may not be accessible to that site. In those cases, IV metronidazole is more preferred, and for 10 days course it is done. Or the alternative is tinidazole. Only side effect of metronidazole is metallic taste in your mouth, and many times patient may have intolerance and develop diarrhea, lose motion out of metronidazole IV drug. So in that case, tinidazole could be preferred. Previously drug available were iodoquinol, paramycin. Okay, and prophylaxis. What is the prophylaxis? Personal hygiene. Okay, now coming to non-pathogenic amoeba. Now non-pathogenic amoeba were first given, the idea of concept was given by Brumt in 1925. Then the first and foremost thing comes here is Entaamba dispar. Okay, I would like to say here, when you are examining stool in weight mount or saline anything, you can't differentiate Entaamba histolytica from Entaamba dispar. Okay, so whenever you are saying your findings to the examiner, do say that Entaamba histolytica or Entaamba dispar. It cannot be differentiated on microscopically. Okay, if you say dispar, then it will be a wise point. The examiner will know that the student knows knows the science. Okay, Entaamba dispar, a unicellular protozoan parasite. It is non-pathogenic. Then another non-pathogenic is Entaamba moscovi. Its pathogenicity is doubtful, right? Previously people were having an idea that no, it's completely non-pathogenic, but nowadays the reports are coming up and the examination are showing no, it's pathogenic and immunocompromised. And Bangladesh, countries like Bangladesh, Iran, they have proved that moscovi can be pathogenic. Okay, so it's doubtful. Okay, this more or less the same, the Entaamba mode of all the Entaamba, whether it is pathogenic or non-pathogenic, have the same mode of transmission, same life cycle. Contaminated excitation occurs. If E histolytica, then it will be causing invasive. If other two, then they are non-invasive. Okay. Then see, whenever you give a weight, whenever you show it to your examiner that this is a cyst or trophozoite of Entaamba histolytica or Entaamba dispar, and I told you that microscopically they cannot be differentiated. One is pathogenic, other is non-pathogenic. For one you are having treatment, for other you don't need a treatment. If there is no treatment needed, and if one is non-pathogenic, then what the clinical signs and symptoms are for which the patient has moved to you. So many times you need to differentiate whether it is E histolytica or E dispar. In those cases, there are 4 tests which are available to differentiate between the two. Agglutinate concavalin A, that is present in histolytica. Cecal ulceration in weaning rat, it's an animal inoculation test. Histolytica again, phagocytosis avici. Histolytica again gives adherence to epithelial cell. Histolytica will give zymodynes. Okay, zymodynes are enzyme complex which are present in histolytica, which helps in its pathogenesis. So it will have 2, 6, 7, 9, 12, 13 and 14, whereas DISPAR will have the other numbers, right? So these are complex tests which you can theoretically remember but hardly done in a lab. Okay, then again few other, like there is available recently, there is a ELISA also available which detect the lectin which is produced in E histolytica but not in E DISPAR, and a PCR molecular test always give you a conclusive result which gives a positive result in case of EH. Okay. Why you need to differentiate? I told you it can be pathogenic, it can be non-pathogenic. If you are giving a diagnosis of EH wrongly, seeing a non-pathogenic one, the clinician will settle down to EH and the patient will be treated with metronidazole. The other underlying condition or maybe other cause for that condition will be not looked for. So many times you need an appropriate diagnosis. Okay. Microscopically it is very difficult to differentiate. Okay, almost the same, it is impossible to differentiate, but when we have looked molecularly, cases are found where the patient has moved to the clinician with the gastrointestinal signs and symptoms but found to be DISPAR or Mashkovai. Okay. Apart from that, okay, this is very important point in point of your practical examination. Many a times examiner will you have to differentiate between a pathogenic Entaamba histolytica from a non-pathogenic cyst of Entaamba coli. Okay, so size is coli is twice bigger than EH. Both are rounded. Cyst wall is much thicker in E. coli. Nuclei is round in histolytica, but it is irregular. Histolytica, as I told you, can present with uninucleate to quadrinucleate. Okay, and uninucleate, if it is uninucleus, then the nucleus will be bigger, and approximately the nucleus, if it is quadrinucleate, the nucleus will be small in size. But in E. coli, the nuclei will be much big, means if uninucleate then bigger in size, but most generally they present as 8 nuclei. Okay, generally they present they are seen as 8 nuclear stays, small size. Then chromatoid bodies, they are hardly seen in a preserved stool. Then trophozoite, very difficult to see in a preserved stool, but if at all found, then E. coli trophozoite are much bigger. Cytoplasm is having much ingested material. Peripheral chromatin are much coarse, large karyosome. Other non-pathogenic like E. hetmani, polychi, I think this are difficult for you to remember. And see, the world has 50 million cases of EH cases every year. So vaccines are always looked for this disease, which is a disease of underdeveloped or developing countries. So, but vaccine yet not possible. Why? Because of the multiple stages: animal host, intracellular location, insect vector. These factors make the vaccine difficult. Still then proposed vaccines are like serine-rich Entaamba histolytica protein, which is the adherence protein for Gal-Gal-Nancy, but this vaccine has not gone beyond phase 1, and doubtful role. Okay, that's what we come to the end of the lecture, and thank you. I don't know how many of you are listening. Okay, if you want, then you can read it. If any time you can write in your theory paper, that's different thing. Okay, I think.